Are retail clinics a friend or foe of health systems? Is virtual specialty care a threat or an opportunity? With all the new digital health solutions emerging, what is the best way for health systems to stay competitive and deliver Amazon-like convenience? Our panelists have a lot to share in this topic, so let's dive right in. Our moderator for this session is Lisa Stunin, Managing Director with Manat Digital and Technology. Lisa, I know you're excited to get going, so I'm going to turn it over to you. The floor is yours.
Thanks a lot, Steve, and welcome everybody. Glad to be here, wherever here is in the virtual world. I'm really lucky to be joined by four experts on this topic, so I'm going to start by letting them introduce themselves. So perhaps, Scott, you want to get started first?
Sure, yeah, thank you very much, Lisa. Glad to be here. My name is Scott Shreve. I'm the founder and CEO of Crossover Health, a national medical group working primarily with large self-insured employers. Thank you.
Great. Ali?
Hi, I'm Ali Posa. I am the founder and the CEO of Babylon. You've seen the bio, I won't waste your time.
Carolyn?
Hi, everyone. I'm Carolyn Whitty. I'm the co-founder and CEO of TIA. TIA is a full-stack care delivery platform creating a new paradigm for modern women's healthcare. We're both direct-to-consumer and partner with health systems to create a female-specific front door that's virtual and in person, and there for women, all those moments in between.
Great. Sylvia?
Hi, I'm Sylvia Ram. I'm the Chief Health Officer of Virtual Care for CityBlock Health. We're a company that provides integrated care for lower income and older Americans in a value-based way.
Excellent. Well, thanks, everybody. So my first question is, this whole idea of primary care being separated from the core health system has been around a long time, right? The Minute Clinic guys started in 2000, although it was not an out-of-the-gate success. And I'm wondering why you think it took so long for standalone primary care, much less virtual primary care, to show up, and why is this a positive development? Who wants to jump in first? Scott, you go.
Sure. So Lisa, we've been swinging the hammer on this for a very, very long time, as you know, a lot of us in the space. But I do think there's a convergence of a lot of factors. Number one, I think people have kind of cycled through the value of primary care. Is it really truly a fundamental part of any strong healthcare system? I think people now recognize that it is, and it's very important. And when it's disaggregated or disintermediated, it creates some challenges. I also think the trend towards really consumerism, digital access, all these innovations over the last 10, 12 years have really enabled people to get access to levels of service, specialty versions of primary care, which you'll hear some of the other panelists share, which are really fantastic. So I think it's an evolution of care models. I think it's an evolution of payment models. And I think the time is really now to really show how these things can work. And so I just think it's been an evolution, kicked off by some of those retail forays, which have led to a whole splintering of all kinds of different opportunities to address niche markets. So I just think it's a natural part of the process to get us here. So
that's interesting, because you said having primary care disaggregated from the bigger system is not optimal, but in fact, I think all of you are in one way or another disaggregated from that system. So how do you reconcile those two things? Sylvia, you want to comment on that?
Yeah, I think that specifically for CityBlock's member population, our members come from lower income communities, are often Black and brown, and have really suffered trauma at the hands of the traditional healthcare system. The fee-for-service system is not set up to think about a person holistically and integrating their behavioral health, their social care, their physical care. And so when you do that, and when you don't treat a person holistically, you end up having this breakthrough care that is really expensive. So they go to the emergency room, they have inpatient admissions for things that if you caught them upstream, you'd really been able to prevent the cost. But our system doesn't pay for that cost upstream in the fee-for-service area. You only pay for it when you get admitted. And so we've been able to look at the life of a person and take some of those dollars and say, look, our member population is spending these dollars if you let them get this bad. Let us help take care of them upstream. And we've been able to funnel that to the right place.
Ellie, you've got kind of the most, I think, virtual model of these, really, or at least the front end of it is, for sure. I mean, how does that work? I mean, talk about disconnected from the normal way things used to work.
If I can actually pick up on the previous conversation, and then I'll get to your thing, but the point you raised, I think this issue of primary care, is it right, is it wrong? And I think that the point Sylvia made is exactly right. The problem is the incentives, right? So imagine if you take a very simple example, your dentist. Imagine you pay the dental insurance policy. Now your dentist is sitting there waiting for you to have a root canal so they can charge you $10,000, right? Imagine now if your insurance company went to your dentist and said, you know what, here is $1,000 for this person, and it's up to you. Do whatever you want to do, right? It's your job to look after this person. What do you think your dentist is going to do? First, they're going to find you wherever you are. They're going to bring you into the clinic. They're going to do a full test of you. They're going to try and catch things very early and keep your teeth as healthy as possible so they never end up with that root canal, right? And that is the problem that we've seen in the US health system, is that nobody's kind of trying to keep the people healthy because all the money is in sick care rather than healthcare. And as Sylvia quite rightly said, it's all about incentives. Now, we are a digital-first organization, but that's only because digitally we can reach more people more frequently in more places. But so that we can take responsibility for their health and keep them healthy. Digital is nothing more than a tool. The fundamental issue we need to get our head through is the model of healthcare. The fee-for-service model has failed. Has made a lot of people a lot of money, but has failed. And it's time to actually align the incentive. Nobody wants to get sick so that somebody can make money out of them. People want to stay healthy, and people should make money by keeping people healthy.
You know, I agree with you, Ali, but, you know, there was this whole era that we went through where everybody was heading to HMOs, and the argument was that, and of course people got prevented from getting care, because the other way of keeping things cheap is don't let anybody get in the door, right? So there were so many roadblocks put up, you know, like, sure, you publish the phone number, but you publish it, you know, in some place nobody could ever find it, and make it difficult. So I don't know. I mean, there's two sides to that coin. I don't know, Carolyn, if you have a point of view on this.
Yeah, I agree with a few different things. I think one of the misaligned incentives is the I think crux of a lot of the issues between what consumers want, what providers want to deliver to patients, and ultimately how people are getting paid for that, or how a hospital, for example, may get paid. But I think the big kind of, when we think about the future of primary care, and you kind of asked this question around, why did it take so long? And there was this kind of first wave of kind of next gen clinics that had left the hospital, so to speak. And I think really addressed this first point around convenience being kind of the first wave of innovation. It was all about whether digital or in a store-in-store model in a pharmacy, or a one medical style clinic. It was all about if we can make something that is expensive and seen as sick care accessible in your daily life, maybe people will use it. Primary care should be preventative care, and maybe then we can kind of from a mental model perspective, redefine what is primary care. And so I think that what I would describe as kind of that first wave, and there's lots of trends, as sort of Scott pointed out, that contributed to that convenience wave of innovation. But I think that as we're starting to hear now, or see now, it's convenience is one part of it. And technology is a big part of making care more convenient, as is location and things like that. But as Sylvia described, I think we're in this next wave, which is really about changing fundamentally what is primary care, to be thinking about whole people instead of just CPT codes or treating sicknesses or things like that. And actually saying, okay, well, what would healthcare be if it was actually about not just sick care, but well care, and treating whole people? And so I think the next wave of innovation we're seeing in primary care is really about redefining what care delivery means, including the practice of medicine, to be more than treating sickness. And that's the kind of space that we're really excited to play in as a rethink of, women's health from a body part, a cervical cancer screening, to something that's about whole people. And when we do that, I think we can make care more accessible, make primary care something people want to engage in, not just when something is wrong, but before something is wrong. and save costs and improve outcomes.
Well, I want to jump in to combine Ali and Carolyn's comments here around what if you have these aligned incentives to be proactive, and then how do you think about being consumer friendly and also using that as a low barrier way to engage and be proactive. One of the examples I see of this at City Block is one of the things that we do is reach out to people digitally, and for our members that's usually text messaging. There are other ways, but for lower income Americans, text messaging is a very effective way to check in on people. And for our people with diabetes, we check in on them to make sure that not only do they have medications and their blood sugars are okay, but do they have food? Because running out of food at the end of the month is one of the main reasons that our members run into problems with their diabetes. And so we did that with one of our members a few months ago, and she wrote back and said, I do have food, but there's been so much going on that I'm depressed and I'm not eating my meals, and I'm not taking my medication because I'm not eating my meals, so my blood sugars have been high. So can you help me? And so we were able to digitally connect her not only with an NP who specialized in diabetes education, but also same day we connected her with a therapist who has a psychiatrist backup that was able to get her into therapy and was able to get her medications. Without doing that in a proactive and also digitally leveraged way, we would never be able to meet our members where they were and take care of them as a whole person. And so this all ties together.
But isn't this?
Yeah, Lisa, I want to just add one. Yeah.
Go ahead.
Go ahead.
No, Scott, you go.
I was just going to add one thing. So the point of, I think, why it took so long to get to some of these innovations is there's a great phrase, architecture is destiny. And if the architecture of payment is a quick transactional thing, there is no way people are going to be doing what Sylvia is talking about. There's just no code to pay for chasing down and doing all these heroics. I mean, that's what we call God's work, right? Just like doing this amazing work to just get to the root of the problem. And I think part of the length of time it's taken is for these new models, payment models to emerge, which allow all this creativity. So I do think this idea of getting more reach with digital, having payment models that allow different types of services that come together and to really drive to this. And then you're going to see this segmentation where you're starting to address specific needs for specific populations through these combinations. And I think it's really enabled by the realignment of incentives through realigning how it's paid. I believe everyone on this call gets paid differently than fee for service. We're off the grid, which allows the care models to now innovate.
Yeah, but that's not new again, Scott. I mean, that is old stuff. Like I was doing that with my old company back in the 80s. So what is the real issue that the traditional health systems have kind of lost their front end to people like all of you guys? Is it that it's inflexible? Is it that it's inconvenient? What is it about that system besides the payment? Because they can do those things too if they choose, right? They've been capitated a lot of these programs before. Why not?
So look, I'm old, right? So I remember the time. That we used to campaign as a student activist to have libraries everywhere. And the reason we campaigned for that was libraries was your means of getting information, right? And today we democratized access for information because anybody who can Google it or search it anywhere on the internet, they can get almost all the information in the world. And it's entirely democratized. I have the same access to the same information on Google that Jeff Bezos has or Bill Gates has. It has almost nothing to do with your wealth, wherever you are. So this idea, it's the same, right? You're saying it's the same idea. I wanted to access information, but for doing so, I needed to have a physical space. I needed to have everything to go there. I had to go there. It needed to be in my proximity. And the whole point of digital is we're taking that model that you said you had in the 80s, but using tools that we didn't have in the 80s to take it away from the physical spaces into people's pockets. My doctor is here 24/7 for me, and not just because I can talk to them, because it's continuously in Babylon is monitoring me. It sees how I sleep. It sees how much activities I do, what I do when I swim. And all of that data allows my doctor, my healthcare people in Babylon to proactively say, hey, I'm noticing you're not doing a great job here or there. So instead of waiting for me to initiate and go through the friction of getting myself there, they can get to it. That's it. It's just a tool And I think that this issue that we used to do something and it went wrong, and the other point about, look, people took advantage of the HMO model. That doesn't make the model wrong. That just makes those people wrong, right? I mean, you can take advantage of anything. That doesn't, it shouldn't make the discredit the point. That's where the job of the governments and the regulators is, to just make sure that people don't sacrifice accessibility or quality for the sake of affordability now that they're responsible for affordability.
So how many of you guys, just raise a hand, have formal relationships with traditional health systems? Okay. So Carolyn and Ali, I'll ask you both. Why is that important for you? And then I'm going to ask the other two of you why you don't. Because I'm curious the difference. You know, why is that important for you, Carolyn?
So a few different reasons. So first is we've spent, we started Tia about 4 years ago. Interestingly, we started out as a digital front door product that was just information, not actually providing care. So we were the Google for women's health, if you will. And we were really good at being that front door, but effectively learned that women wanted Tia to be their doctor too, their doctor in their pocket and their doctor in the real world. Not all of women's health care can be delivered on the internet, to say the obvious. And so we essentially found Tia
really tough to do.
found essentially people bringing Tia with them to their doctor's office. And, we were care coordinator, translator, navigator, care provider, all the things that we weren't really set up to be, and evolved to a full stack model. When we did that, we effectively had to define, well, when we say we're a care provider in women's health, what does that mean? Are we an OBGYN? Are we a primary care provider? Are we a mental health care provider? What are we? And we've effectively spent the last couple of years really defining our model as the front door, being that medical home model for women. And that fuses primary care, outpatient GYN, mental health, nutrition, pelvic floor PT, and a whole bunch of services into an integrated model that treats the whole person. All that is said, there's still a lot of things that we can't do, and namely in women's health, delivering babies and really important things like that require deep integration with health systems who can play catch for critical parts of women's care journeys that we can't provide ourselves. So that's the first and foremost reason, is the belief in connected care, and that there's value in integration, and that our innovation is in preventative healthcare, not deep, complex, high acuity specialty care, and that enabling those handoffs to be smooth and seamless can improve outcomes. The second is really actually around access. So Scott, I will correct you. Tia actually isn't a fee-for-service model today. And so one of the things that we've done is we call it we've reinvented preventative healthcare within the confines of the fee-for-service model, which is essentially helping women hack their preventative healthcare benefits through the ACA. So you've taken your essential benefits that are 100% covered under all plans, including Medicaid, and beefed them up, and may help women squeeze the sponge out of their healthcare benefits. And so to make that model work, to make this new standard of care that Tia is building more accessible to more people, essentially requires us to be contracted with every single insurance plan, and health systems help us do that. So when we can partner with health systems, we get more insurance contracts and more women can use Tia. So those are the two big reasons we partner with health systems.
Ali, do you have anything to add to that one?
I miss short, and she said it beautifully.
All right. So why not be connected to the health system, Sylvia?
So we do not work under the fee-for-service model, and having come from the health system side previously, health systems just haven't taken on enough risk to be able to kind of share that pie. Most of it is shared savings. Many health systems are, only have one-sided risk, and so we have talked to different health systems, but there really would need to be sort of an evolution in risk contracting to be able to make sense for our model to make sense. Because if you look at health systems and why they would contract with somebody like a One Medical, to throw that out there, for example, again, having been on the health system side and looked at this, most health systems consider primary care, but I'll be generalized here, stereotype here, but consider primary care to be a loss leader for their more expensive services. And so that works with the One Medical by bringing people in and being really, really good at patient acquisition. A model like City Block is really, really based upon removing acute care, removing high cost care. And so a health system would really have to have full risk to want to be able to bring that on to them and have that kind of partnership.
What about you, Scott?
Yeah, so for us, we always need health system partners to refer this higher level of care to. And I think that's where they should really develop the expertise. And to Sylvia's point, a lot of the health system experience we've had is that primary care is a loss leader. And to be a little bit more blunt, it's there to feed the MRI machines at the hospital. And we just disagree. We like actually being independent and being able to refer to any service in the community, in the hospital health system, and be a fiduciary for the patients and to really guide them to where we can go. So we always have relationships, but they're not formal because we like the ability to be independent, non-conflicted fiduciary for the patient to send them to the very best place, regardless of, its affiliation. So that independence has been helpful for us. And because we are also not on any fee-for-service schedule, it's a value-based system. We have that independence. And so that's been very effective for us. That's the approach we've taken.
So what do the patients lose?
Sorry, Lisa, can I just make a thing on what Scott said? Because I think it's a critical point. This issue of independence and whose agent you are and the patient being able to trust your judgment, it's critical. I won't name it because it's irrelevant, but I read in the S1 of one of the companies that filed for an IPO, that actually where they make their money is on the referral they receive back from the hospitals. So basically you refer to the hospital to feed the MRI machine, you get a kickback. In most countries in the world, that would be illegal, right? And in the United States, somehow we accept it, so much so that they put it in an S1 and boast about it, right? Imagine now you're the patient and you knew that, and that was on their door. And it said that actually, if you come here, I have a financial incentive to send you to this hospital that gives me the highest kickback, and you should know that. And I don't see it on those people's doors, by the way. And I'm not calling who they are or what they are, I'm just calling the practice. So what Scott said goes to the root of the issue. You need to align incentives and you need to have complete transparency where those incentives are and how it works for the system to work. In the United States, we managed to hide a lot of these incentives and we managed to create something that all of us know has challenges today. But the best way to deal with those challenges, first and foremost, is transparency and this kind of conversations. And I hope that I'm not offending anybody by saying what I say, but I think it's important to talk bluntly about what is going wrong rather than be too polite about it.
I unfortunately happen to agree with you, Ali, about this. And I think the challenge works on the other side too, because I think what happens in a lot of primary care models, not necessarily any of yours, of course, but is you refer to who you like. You refer to who you play golf with. You refer to who you know. You refer to who, patted you on the back when you gave them patient last time. And it's not any more scientific or legitimate, except for the fact that it might not be in the form of bribery, right? So it's just, I think it's a real complicated mix. And I wonder, from a continuity of care point, how you overcome the problem of discontinuity of care in these disconnected models. And by the way, I'm not, suggesting that it's so perfect on the other side either.
No, it's not. And look, let me just add this up very quickly. The problem is even worse than that, right? It's not even who they play golf with. It's actually what they know. It takes 17 years in healthcare for best practice to become common practice. And I'm yet to see a practitioner who says I'm at the bottom of that 17-year scale, right? They all think that, and just the reality is people don't know what is the best practice because so much happens. It's very hard to keep up, which goes to your second point, which is at the end is all about standardization. And technology, again, is a tool to standardize, right? If I can see for this disease and I can check and see that's the best treatment and the most up-to-date treatment, and this is the best practitioner for it, and that's statistically why that's the best practitioner for it, all of that subjectivity goes away. Healthcare is still highly subjective, and yet is a scientific endeavor that needs to be highly objective. I mean, I'm a physicist, not a physician. In physics, you don't use subjective kind of things when you're doing your experiments. But when it comes to human body, we still use a lot of subjectivity and say it's intuition, it's this, it's that. The reality is we need to bring science back into medicine at primary care, at the entry level. Data should speak.
So should traditional health systems be afraid of you guys?
Of course not. I'm 5'6", look like that, so there's nothing to be afraid of.
Yeah, I actually, so Lisa, that's a great question. I just don't think so. I mean, listen, we aren't a specialty hospital. We don't have, MRI machines in these outpatient physical centers.
Yeah, but you have the front end of referral source.
Yes, I am. So the thing is, then they should compete on the thing that they're expert at, right? They have the specialists, they have all the high powered tertiary kind of services, and they should compete on those. What I find interesting is that health systems kind of view primary care as a loss leader, a feeder to the system. I think, I'd rather see people competing for the value of their services and the service level and the integration, as opposed to kind of doing a poor job, trying to do everything and do, it poorly. So I don't think they should be afraid at all. I think what we're looking for is where are the centers of excellence? Where are those things where I can make sure I can get my patients to the best care? Because that's all I care about. If you can do it better, if you can create a different service level, service experience, you can show that you have better data, of course I'm going to send patients to you. And that's where I'd love to see the health systems compete. And I want to say one other thing, Lisa, to your point, this idea of who you refer to, I do think there is a ton of subjectivity. And that's where I think, solutions like Allie's, others, where there can be more intelligence for our providers. We would love to know who has the best quality of the 10 cardiologists on the panel. We do our very best to figure that out. And there's all kinds of people trying to solve that problem. And when they do, absolutely, I'm sending the patients to wherever the best quality is, because they take 95% of my recommendations. And so that's kind of the point. If you can get more data to the people who are steering that, I just think it's more effective. I'd love to see the health systems compete on that, as opposed to thinking we're a threat to their primary care group, which they are just using as a loss leader anyway.
Although, I just think it's Carol, I'll point to you. I think okay, I'll take it at face value for 1 minute, Scott, until I see that now the specialties are starting to peel off too. You've got women's health and gynecology peeling off. You got radiology peeling off. You got all these different things starting to peel off into their specialty programs and networks separate from the hospital. Is the logical conclusion of all this that a hospital is just an emergency room and expensive iron in the end?
Not even that, because we're doing ED at home. So
okay, fine.
Yeah.
But I mean,
Sylvia's going for the whole bundle there. Yeah.
That is a good point, Sylvia. I mean,
I think the biggest threat to the hospital is consumerization. And if they don't meet consumers' desire to have more transparency, to have more personalized care. When I say personalized care, I mean choices around where they spend their dollars, where they go to. We see our patients want to see we match our patients with therapists based off race or ethnicity or language preferences. There's all sorts of types of preferences that consumers want in determining when they're accessing their care. Talk about women's health and pregnancy. There's a huge array of pregnancy care, from midwife-centric models to much more medicalized models, to birthing centers, to religious organizations, non-religious organizations. We see TIA as a role, as a sort of middleman in certain regard. That's all about transparency, enabling patients to maximize their choices and all their healthcare decisions they make, big or small, including where they seek to go for specialty care. And so I think the real threat is not a TIA to a health system. It's like, can a health system, to what Scott mentioned, like become more transparent, actually help patients and providers understand why one health system is a center of excellence for this versus that. And some of the, I think, more qualitative aspects of care as related to culturally informed care, and some of these sort of really important topics that are increasingly prioritized by patients, particularly sort of younger patients, and the choices they make with respect to where they do or don't get care. And so if they don't meet patients, the growing demand there, that's when I think they won't really be able to compete. And any sort of players like a TIA or a City Block or all of us here, we won't I think that's when all care will truly have left the hospital, so to speak, and consumers would be going elsewhere.
Sorry, can I just gently disagree? And look, I ran and built what is today the largest chain of hospitals in UK. So I actually built and ran hospitals. In average, any of us go to a hospital once every 20 years. And if you're very unlucky, in the last 2 years of our lives alone. For those events, what hospitals do, I cannot do. And I don't think anybody in here can, right? When it comes to traumatic surgery, cancer treatments at its highest level, right? So hospitals have a very important role to play. And what Nofli was saying, they are doing God's work, right? I mean, so let's not undermine what these people do. It's a very important part of the value chain. It's just that what we're all saying is that not the entire value chain should happen there, so that once that important part needs to happen, they have the referral, right? That's all we're saying. But I think, and by the way, let's not forget, 5 billion out of the 7 billion human beings out there have no access to any kind of surgery or secondary care. Zero.
Yeah, but we're focused in the US.
I will focus on how do I cover the next 5 billion and just instead of just the 2. And there is a massive growth for me in there too. We all have a role to play, and we should not undermine each other. We should just not look at each other even as competitors in the sector. We should look at each other as peers who should link in, join up to serve patients in a much better way than what we're doing today.
So Optum is now the largest employer of physicians, I believe, in clinics. And they also now own a large number of ambulatory surgical centers. So they are also peeling the surgery out. Do you guys consider them your peers? Are they similar to you in terms of the role they play in the healthcare system continuum, or are they a whole different animal altogether?
Look, I just say one sentence on this. We all talk about this competition, this, that, the other. I tell you, we did tens of millions of dollars of revenue last year, about 80 million. This year we'll do 3-4 times that, so hundreds of millions of dollars of revenue. Even if you get to 1% of UK healthcare, that is $30 billion. That's 100-fold where we will be today, right? My biggest job is how to go and not fall apart if I'm growing 100-fold. That leaves 99% for the likes of Optum and everybody else to get to. So this obsession, again, with competition, we're both beneficiaries, all of us are beneficiaries of 2 trends. On one hand, we are seeing fee-for-service moving towards value-based, massively benefits. On the other hand, we are seeing analog, brick and mortar moving to digital, massively benefit us. Right, so I don't need to worry about who's the competition, who else is doing what. I just need to worry about, can I get enough supply to deliver the massive demand that I'm facing all the time? And can I do it safely, soundly, and properly? I'm sure that's true for all of us.
Do you feel the same way, Scott?
Yeah, so here's how I think about this. And I think about the concept of the long tail, right? So originally, back 20 years ago, Lisa, when we were all doing this, like there was just one kind of thing. And what I think happens when there's just one kind of type of offering, it's just you lose who the customer is and you're not serving their needs. And when you're not serving their needs, all these things emerge. And I think Carolyn would agree with that. Like, hey, there's like a new discipline around women's health and addressing a specific niche, and technology enables that and so forth. And City Block is approaching it in a whole different way. So I just feel like we're starting to address the long tail, which allows all these other new models to emerge. I view United and their effort, they're part of the traditional system and they're doing some innovation within that. And they're huge and they're big, but there's this whole long tail that all of us are serving, and we're gonna keep moving up and getting involved and hopefully, presenting choice and opportunities to show that other models can work. How do we look at them? Like I kind of view them as they're innovating within the traditional system, and a lot of us are innovating kind of on that long tail and out, and we'll have to see where that all evolves. But I do agree with Ollie that, listen, this is a $4 trillion problem. All comers are welcome to solve this, and we're going to keep kind of fighting for this. The last point I'll make is that with technology, again, I think that while there's a disaggregation and potentially pulling apart of all these services, we're also stitching those all back together, right? So if Kaiser is vertically integrated, has the health system, the plan, and the doctors all lined up, can you recreate that virtually through some of this? And I think the term was mentioned, full stack, care. I do think in the future, people will join an organization that does the work of stringing all these disparate services together to keep it as a coordinated and integrated whole. And that's actually, I think what a lot of us are actually ultimately building is these kind of membership, like you join this thing that actually keeps all these sets of services for your unique interests and preferences and needs together. And actually that's what really Crossover is trying to build is for our segment of the population, can we string together all these things through a combination of in-person, online, technologies, services, and programs to make your journey through health much more coordinated, organized. And again, it sounds a little Pollyannish, but that's exactly what we're bending our backs to build.
Sylvia, you look like you wanted to add to this conversation.
Oh, there's so many things to add. Yeah, so again, my job on the health system side was to think about disruptors. And so yeah, I think that health systems should be scared, but it's
to thwart them or in order to integrate them.
both. It was really to understand what was going on in healthcare and to look around corners and to see what we needed to do to evolve to be able to maintain the honor of being able to serve the people that we were serving. This is like, how do we acquire new patients? How do we retain them? And have the deep understanding that if we weren't understanding what other organizations were doing, not just in health systems, if you look at health systems and how they thought about competitors, as recently as a few years ago, and some health systems still think this way, they really only think of other health systems in their geographic region. Yep. And I was like, look, when I was at Amwell, I was working with famous health systems in the Midwest who are like, your patients in New Jersey are our patients, are our potential patients, right? They saw themselves as having a national reach. And other local health systems, even larger regional health systems, don't think about these large innovative health systems as their competitors, but they really are. They continue to be. So understanding that mind shift, even like nationalizing other competitors, but then thinking about, Amazon Care, then thinking about Walmart. It's really less about individual services and more about how do you continue to make care convenient, move care out of the hospital, and own some of that. If, for example, hospitals don't start to figure out how to do home hospital or hospital without walls, whatever you want to talk about, then other people are going to do it, and they're going to take that away. So how do you continue to evolve in that way?
So as more and more of the care goes virtual and digital, to your collective points, even though some of you also have physical manifestations of what you do, how do you mitigate creating barriers that are kind of amplified by the digital divide? How do you not make it worse?
I mean, I can hop in with that as well. Again, our members are, again, lower income and older, and so run into a lot of technology problems. And so we again, because we get assigned member populations, and it's not just who comes through our door. We need to proactively reach out to them and take care of people. We needed to figure out how to continue to take care of people. Not having them come into the office wasn't an option. And so we ended up doing a lot of proactive outreach, first digitally, found out that people were actually okay with owning digital platforms, but digital literacy was not allowing them to get online and reach us in a way that we felt connected. So we started delivering technology to people's homes, using some of the delivery systems around New York to try to do that. Found out that still digital literacy was a big issue. We had a lot of no-shows. We had people who couldn't understand how to use the technology. And so we actually set up a dispatch system of the EMTs that go into people's homes and bring equipment with them. And it allows them to take vitals. It allows them to do labs. It allows them to really fill out the visit and then have a telemedicine visit with a provider or physician on the other end. So we make sure that they get the services that they need. And that has been very successful in getting across the digital divide for our members.
How do you think about that, Scott?
Yeah, I think those are great. One of the things that we've found is kind of the cultural sensitivities. I'll address that. So when we're serving populations in the Bay Area versus, in Kentucky or something, we really found that it's important to have providers that look like the population, that speak the languages, that are culturally sensitive and understand how to deliver care in that context. And I think we had some misses early on when we didn't hire right for that. And so in addition to everything was just said about digital, like all these extra hoops you have to jump through to get there, we found the same thing with culture and languages and preferences were really important to tune into. So that's actually become part of how we culturally train our care teams to make sure that you're aware of some of these issues and address them. And so that's been how we've kind of started to address that. And we're really proud of the diversity numbers we've had in our care teams and the mix of people we're hiring and their backgrounds and languages they speak. It's a challenge to make and to map that, but it pays off in spades when you can get that right.
Interesting. Okay. Anybody else have a comment on the digital divide problem? I mean, I think about your program, Allie, and I'm just thinking about the U.S. now, okay? And there's a lot of people that still don't have smartphones. There's a lot of people that still don't have broadband. They can't, and not to mention they may feel uncomfortable with an AI, front end interface. How do you think about that and ensuring that you don't amplify that problem?
I know you just want to talk about US, but let's give you an example that is as far away from the US as you can imagine. We serve 20%, 25% now, I think, the population of Rwanda, one of culturally richest but financially poorest countries in the world, where 99% of the people do not have mobile phones. And today we would do 5,000 to 6,000 consultations in that country. To put this in perspective, if I was in the United States, that would be equivalent of us doing today 300,000 consultations in the United States, right? Because they're only a country of 10 million people and we're only allowed to see half the population, and the 15 we cannot see for some. So just think about this, right? If we can serve them there.
How do you do it? How do you do it?
We do it on ordinary feature phones, right? And we don't do it on smartphones. People need to talk to another doctor. We don't use the AI in front of them. We use it in our call centers, right? So it's just basically adapting what you have to the community you have. Today in the United States, 7 months ago, we didn't exist in the United States, give or take. Today we have 90,000 patients for whom we take the entire budget, right, value-based budget. And we got 5 million patients for whom we get paid to do telemedicine, fee-for-service, right? So the beauty of technology is it allows us in a year to go from nowhere to millions of people or almost 100,000 complete value-based thing. But that's all it does. It's just an ability to allow us to be scalable, and it's a tool. The foundation is delivery of care, as if I was sitting next to you, human to human, and doing so. So I think as long as we look at technology as just that tool and then adapt it, rather than force our members to use what we have, we'll get there always.
So do you think, this is the last question, we only have three minutes left. I'm going to ask you quick, we're going to do lightning round style here. The inevitable path of healthcare is towards integration or towards consolidation. I'll say that, not integration, consolidation. Notwithstanding the fact that you're all going to be gigantic companies in your own right, I'm sure. In the end, what does the system look like? Is it primarily driven by health systems? Is it primarily driven by payers or integrated stack like a Kaiser or an Optum kind of model? Or is it, a whole bunch of different specialized plans like you guys have separated out? What do you think? What's your vote, Sylvia? Where does it end up 25 years from now?
Okay, I'll give my optimistic answer and save the cynical answer for later. The optimistic answer is that we're able to figure out a combined payment method that doesn't have so much red tape, that allows us to provide the right care by the right people at the right time to take care of people holistically. That's my optimistic.
In what entity? What's the entity that controls that?
How optimistic? We're going to have a single payer system, and we're going to
be able to, the government.
Yes, that's right. Contract with holistic provider organizations. Going right there.
Scott, how about you?
I'm developing a rash. Yeah, no problem. But no, so different viewpoint is I actually believe that there will be a new type of membership-based organizations that people join based on preferences and others, tech-enabled, powered, that will then be the thing that integrates and coordinates actually how the care gets delivered. That's actually where I think it goes. And people will join these different membership groups based on preferences or other things. And I think that's the world that we're trying to build is this thing that you can actually join that actually guides, steers, navigates, and keeps it coordinated when you have that independence. Yeah, so I think it's 10 years out. Yeah, I think over the next decade, right? I think you're going to, if you speed as long as what we're doing now with technology, integration, coordination with all these different specialty type services, I think some of them will get to scale. And I think you'll see that in the next decade for sure.
Right. 20-second answer, Ali. What do you got?
I was born in the Middle East, and there they say if you want God to laugh, you give her your 2-year plan. Who knows? The job of entrepreneurs is to be adaptable. So, and it really, because we work globally, we basically, whatever is happening in Europe, we adjust to that. Africa, we adjust to that. Asia to that. And whichever way the United States goes, we'll adjust to that. Our view is the way we deliver healthcare rather than getting the system to be ours.
And what about you, Carolyn? What's your thought?
I think 5 to 10 years from now, there'll be a handful of brands that full stack platforms that have relationships with consumers in meaningful ways. I think Scott used the word membership, not membership in like a financial sense, but I mean, I think I'm with you on believing that consumers, people join TIA. They don't use TIA, they join. And it's a community, it's a relationship. Healthcare is ultimately about relationships, and technology is just a tool. And people, I think ultimately there will be a handful of brands that will be built in this space that will own those relationships with those populations in deep, meaningful ways that will determine where and how they get care. And the ability for those handful of brands to provide a subset of services, to enable access to services they don't provide, to create connected care ecosystems. That's what I hope, and I think that healthcare really needs. There's a lot of payment work that needs to happen underneath that to make that all work, but really do believe that consumers will drive this, and it won't be a healthcare system, it won't be a payer, but it will be different populations that are not niche, but control the dollars, and they will tell all of us where they will spend them.
I'm going to call you later for my list of stocks to short. So looking forward to that. Really great to see all you guys. Thank you so much for engaging in the conversation. I wish we had all day to talk about this. It's great stuff.
Thanks, all.
Thank
Okay,
you.
that takes us to the end of this session. Thank you to the esteemed panel for an engaging session and to our audience for the great questions.